Dr. Jennifer Obel, you are a medical oncologist.
Yes, I am.
At the NorthShore University Health System, where you're also assistant clinical professor of medicine at the University of Chicago. And you are a member of ASCO's communications committee. So it's great to talk to you.
Thank you.
And we're going to talk about two things today. We're going to talk about the GI cancers, in particular colorectal cancer, and we're going to talk a bit about ovarian cancer too.
Sounds great. I'd love to share all the information we learned today at ASCO.
So let's talk about the colon first.
Okay. Well, I think what we're learning is that colon cancer really isn't one disease process. Like we've learned in breast cancer. There's HER2 positive breast cancer, ER positive breast cancer, and there's actually multiple gene abnormalities that we see in colon cancer. In the oral poster discussion section, we learned that not only is there KRAS mutated colon cancer, but colon cancers that have BRAF mutations. Those mutations are highly indicative of poor prognosis. Patients who have those mutations in their tumor, when their tumor recurs, they do much worse with a very low survival rate.
These are predictive markers.
They are, when we talk about markers, let's just define them. There are predictive markers, and a predictive marker is a marker that predicts benefit from chemotherapy. So KRAS is a predictive marker. We cannot use a group of drugs called epidermal growth factor inhibitors. When the KRAS mutation is present, the cancer cell sort of outsmarts binding of those antibodies. So it's predictive. It's not clearly prognostic. A prognostic marker is a marker that portends prognosis. So patients do better or worse with that marker. So we all understand breast cancer much better, so I'll use the analogy. HER2 positive breast cancer, that is predictive and prognostic. HER2 positive breast cancer patients do worse, but it also predicts to response for Herceptin. Now what we learned today is that BRAF is prognostic but not predictive for response to epidermal growth factor. And this is really important because we've seen a signal of BRAF in early studies. Patients were enrolled with metastatic disease who were treated with cetuximab and chemotherapy, and they did very poorly. And what we didn't understand was, did they just not respond to the drugs, or did they just do badly? So then researchers went back. You always need a control arm to understand things. And they looked at patients with metastatic colon cancer who had never been treated, and they took those patients in a large randomized studies who had BRAF mutations and analyzed how they did when they had chemotherapy versus chemotherapy and the epidermal growth factor drug, cetuximab or panitumumab, when they had BRAF mutations. And they actually found that the BRAF mutations, while they did poorly in general, they still responded and had better survival when they were given the epidermal growth factor inhibitors. So that's prognostic but not predictive.
What is the percentage of patients that have
These markers?
Yes.
So KRAS mutated patients are about 40% of all patients. BRAF, the number is lower, it's 10% of patients. But we know by analyzing these studies, when their cancer comes back, they do poorly.
And the course of treatment then obviously is dictated by the results of
these testing.
Exactly.
And I think the KRAS test is essential, and we always test patients. And BRAF is important in some ways prognostically to give us information about how their disease course will be.
So how will this now begin to change the standard of care from what we knew just a couple of years ago?
So I think it's clear that we can still use these agents in BRAF mutated patients. And I think it's a molecular marker that's as helpful as staging pathology. Mm-hmm. When we look at a patient's tumor, we're trying to predict for how well they'll do. And we know these patients don't do as well. It helps give us more information.